Chapter 3, Electrical Activity of the Heart. All right, different heart cells serve different functions. One of the functions that we will have specialization in related to the heart will be automaticity. So the main site of automaticity is, of course, the SA node. The SA node is the normal pacemaker for the heart. It is the pacemaker because it has the highest intrinsic rhythm or intrinsic rate. These cells spontaneously depolarize to threshold, and they have a rate of about 100 beats per minute. So does that mean that the normal heart rate is 100 beats per minute? I hope you said no, because the normal heart rate is between 60 and 100. So how do we reconcile that if it has an intrinsic rhythm of 100 beats per minute, the SA node, why don't we have a normal heart rate of 100? Well, the answer to that is, remember that the SA node is under parasympathetic tone. And as we will discuss, parasympathetics decrease heart rate. So that's the reason it's not running at its normal intrinsic rhythm, again, because of parasympathetic tone. Next is the AV node. It has the second highest intrinsic rhythm, somewhere about 40 to 60 beats per minute, and typically becomes the pacemaker if the SA node gets damaged. Third are Purkinje cells. These are not really specialized for automaticity. AV is not really specialized for automaticity either. Really, the main specialized is the SA node. But Purkinje cells do show a spontaneous depolarization at close to 35 beats per minute. And we bring in that AV node and the Purkinje cells because remember, we have a particular arrhythmia, third-degree heart block, where AV node or Purkinje cells become the pacemaker for the ventricle. That's not the normal scenario. In the normal heart, the SA node is the pacemaker for atria and ventricle, but we can have a dissociation between atria and ventricle. That's third-degree heart block, and as we will see, they typically have a very slow rhythm. All right, the AV node is really specialized for slow conduction. That's what it does. Mechanism for the slow conduction. Three big things. Number one, small diameter fibers. Remember back to the nerve when we talked about nerve conduction velocity, and we said conduction velocity was directly related to the diameter. Well, the same is true for cardiac tissue. So AV node is specialized for slow conduction, and it has small diameter fibers. That's one of the mechanisms. Second is it has a low density of gap junctions. Hopefully this will make sense. More gap junctions, the faster the conduction. Less gap junctions, the slower the conduction. Because remember, in the heart, we have gap junctions, we have cell-to-cell conduction. And third is the rate of depolarization, most specifically, as we will discuss, for phase 0, the upstroke of the action potential. So phase 0 will be our upstroke of the action potential, and the rate of change in potential, or in other words, the rate of depolarization, or you could say the slope of phase 0, influences conduction velocity. Steeper the slope, faster the conduction velocity. The lower the slope, the less the conduction velocity. Now this does have some impact in nerve as well. We just don't typically see that big a change in the upstroke of the action potential in nerves. But in cardiac tissue, it becomes very, very important. Now our Purkinje cells, they're really specialized for rapid conduction. Boy, they move that thing fast. The idea is once we get it to the bundle branches, we have these Purkinje cells and Purkinje fibers is to just bam! Send it through that ventricle very, very rapidly. Why? Well, just the opposite of the AV node. We have large diameter fibers, we have a lot of gap junctions, and the rate of depolarization for phase 0 is very rapid. Again, the upstroke of the action potential, or the slope of phase 0, is very high. These cells are part of the His-Purkinje system of the ventricles. Again, their job, rapid conduction. We want to get that signal to the ventricular myocytes basically at the same time so that all those ventricular myocytes depolarize at the same time and the heart can contract in unison. All right, the myocytes, even though they conduct, the myocytes are really specialized for contraction because they have the protein machinery needed to contract. Actin, myosin, troponin, tropomyosin, titin, all of those players that are discussed in section 3 in the muscle section. The normal conduction pathway, or any time we get excitation of one cell to threshold, it leads to an action potential throughout the heart. So whoever gets to threshold first ends up being the pacemaker. As we indicated, the SA node is really specialized for that, so that's effectively its job. So we're going to start in the normal heart with a depolarization to threshold and then an action potential in the SA node. This action potential sweeps across the atria, and it also gets delivered directly to the AV node via internodal fibers. Whereas we indicated before, AV node's job is to slow the conduction down so that it creates a delay. And the rationale, of course, for that is the atria contract, then the ventricles contract. We get a little bit of that filling of blood, that atrial kick. But then once we get to the Purkinje fibers, they're designed for very rapid conduction, so they're going to send that signal throughout the ventricular muscle, those ventricular myocytes, very, very rapidly, depolarizing all basically simultaneously, so they all contract in unison. So that's our normal conduction pathway. All right, we'll start the discussion off with non-nodal cells. So in other words, atrial myocytes, ventricular myocytes, and those Purkinje cells that we discussed. In cardiac tissue, we have a very high resting potassium conductance in these cells. We have a lot of ungated, which we also called leak channels, if you remember from the previous chapter. We have ungated or leak channels. These are always open. And so potassium is going to efflux because remember, it's trying to get to the equilibrium potential of potassium, which is around minus 95 millivolts. Now, the other aspect to the heart, which we didn't discuss in nerve because this is related to the heart, we always have to remember, even though we have a lot of similarities between nerve and heart, they're not the same. The heart has what are called inward rectifying potassium channels, IK1. These are voltage-gated potassium channels, but they're opposite of the ones we discussed for nerve, because these are open at rest. So we have leak channels for potassium, and we have open voltage-gated potassium channels. Hence the reason that potassium conductance is so high at rest. Resting membrane potential is very, very close to the equilibrium potential for potassium. All right, these channels will be closed by depolarization, and then they will open once again as the membrane starts to repolarize. So they're going to participate in the repolarization process. So again, at rest, we have leak channels for potassium, and we have open voltage-gated potassium channels, which are referred to as the inward rectifier or inward rectifying channels, IK1. All right, this slide has quite a bit of information, so let's just kind of walk our way through it and think about it. This is going to be the cardiac action potential, again, in non-nodal cells. So look at the figure. On the x-axis, we have time for all of the graphs. But what we have on the top is membrane potential. So there we're looking at the action potential. Then we have sodium conductance, then calcium conductance. There's our inward rectifier, IK1. We're also going to bring in another voltage-gated potassium channel called the delayed rectifier, IKR. In reality, we have even a lot more potassium channels, but it's not really high yield for step 1 to go into the details and the complexity of all those potassium channels. So we're not going to go into that. So we're just going to talk about the inward rectifier. Again, open at rest. Notice that conductance in the inward rectifier is high before we get an action potential. In other words, it's high at rest. The delayed rectifier is going to behave just like the voltage-gated potassium channels we discussed for nerve and skeletal muscle. All right, we have 5 phases to the cardiac action potential, 0, 1, 2, 3, and 4. So we'll just walk our way through, hitting the key points and trying to integrate in some important information related to these, because this is the cardiac action potential, which is, of course, going to be very high yield for step 1. All right, we'll start with phase 0. Phase 0 is the upstroke of the action potential. In non-nodal cells, this is just like nerve, this is just like skeletal muscle. This is the opening of the fast sodium channels. Remember, those fast sodium channels are voltage-gated sodium channels. As we indicated before, the slope of this phase 0, okay, or in other words, the rate of change in potential for the upstroke of the action potential influences conduction velocity. And why is that a big point? Number one, right here, stimulation of beta-1 receptors increases this slope, and as a result will increase conduction velocity through the heart. So that slope of phase 0, that slope of the upstroke of the action potential, is a very important concept to work with for this step. Now, another reason that the cardiac action potentials are so high yield is because an EKG or ECG, whatever you prefer to call it. I'm going to call it EKG. The EKG is a recording of the cardiac action potentials. So, big point here is phase 0 generates the QRS complex on the EKG. Again, phase 0 generates the QRS complex on the EKG. All right, phase 1 is quite brief, and we're really not going to spend much time on this because it's not very high yield. This is just a slight repolarization mediated by a transient potassium current. Don't forget that the sodium channels, as membrane potential becomes positive, they transition into the inactivated state. And so we're going to see a rapid reduction in sodium conductance. We'll show that again in just a moment. But that's the bottom line for phase 1. All right, phase 2 is the plateau phase. This is what gives the cardiac action potential in non-nodal cells. Again, non-nodal cells. This is what gives it its long duration. Phase 2, the plateau. The depolarization opens both voltage-gated calcium, L-type calcium channel primarily, and potassium channel, and our delayed rectifier is one of the many potassium channels. We bring in that delayed rectifier because that one becomes very important from a clinical perspective. Drugs that interact with this or tend to block this or may open this channel, this delayed rectifier, we know are going to have arrhythmogenic properties, and so that's why we bring in this IKR. But the bottom line is we're opening voltage-gated calcium and voltage-gated potassium. This inward calcium current gets offset by the outward potassium current. Remember, calcium, if I open a calcium channel, we would cause further depolarization. By opening a potassium channel, we're going to try to drive the cell back toward equilibrium for potassium, which is minus 95. Well, that would be repolarization. So the calcium's trying to depolarize, the potassium's trying to repolarize, and as a result, we get a plateau. Now, this calcium that comes in from the extracellular space will cause the release of calcium from the SR. We call this calcium-induced calcium release, and we're going to see crossbred cycling and muscle contraction. Again, this idea of calcium-induced calcium release is covered in section 3 when we discuss muscle. It's mostly skeletal muscle, but skeletal and cardiac have a lot of similarities. This generates the ST segment of the EKG. The plateau, again, generates the ST segment of the EKG. Now, this long duration action potential, which again we will cover in the next section, this long duration action potential will prevent tetany in cardiac muscle. And this is a good thing. Even though tetany is more force, hey, we need that heart to relax. Remember, as we're going to discuss, the heart is going to do two things in systole, pressurize and eject, and it's going to do two things in diastole, depressurize and refill. That's why tetany is not beneficial for the heart, because it needs to depressurize and refill. All right, phase 3 is repolarization. Hey, and remember, in nerve, it was potassium. In skeletal muscle is potassium. In cardiac muscle is potassium. The L-type calcium channels begin to close. We have still open my delayed rectifier potassium. So as those calcium channels are closing, now we're driving repolarization because of the high potassium conductance. Don't forget what we mentioned earlier. My inward rectifier channel begins to open as the cell repolarizes. So again, that's just saying a big increase in potassium conductance, or in other words, a very high potassium conductance when the calcium conductance is going down. So that drives repolarization. On the EKG, this is the T wave. Phase 4 is our resting membrane potential, so we go back to rest. The fast sodium, the L-type calcium, and the rectifier, my delayed rectifier potassium channels are all closed, but my inward rectifier, again voltage gated, that's open at rest, they will be open. They'll remain in the open state. Remember, they opened up during that repolarization. And we have ungated potassium, we have the inward rectifier potassium, and thus a very high resting potassium conductance for the heart. And that's the reason that extracellular potassium, remember we talked about that in previous chapter, that extracellular potassium is so influential. It really influences excitability of nerves, but also excitability of the heart. In fact, that's what we're really concerned about in hyper and hypokalemia, are dangerous arrhythmias. Okay, that was action potentials for non-nodal cells. Now let's look at action potential for the nodal cells. Here's a typical action potential for a nodal cell, most likely an SA node cell. And we can notice right away that we're missing two phases, 1 and 2. We still have 0, 3, and 4, but we don't have phases 1 and 2 in the nodal cells. Now, a very important point about nodal cells is they don't have fast sodium channels. So the upstroke of the action potential is not going to be a sodium current. They do not have fast sodium channels. So that's a big key. Again, this could be SA or AV node. They're going to be very similar. What's going to be different in SA and AV node will be phase 4. All right, phase 4 is our resting membrane potential. But notice it's not very resting, is it? There is a spontaneous depolarization, and we need to know mechanistically what's driving that spontaneous depolarization. All right, this phase 4, spontaneous depolarization, also called pacemaker potential. You could also call it a pre-potential. I think most people call it pacemaker potential now. But this phase 4, this pacemaker potential, one of the currents is an inward calcium current. And this is primarily due to T-type calcium channels. One of the big differences between T and L-type calcium channels is the membrane potential in which they open up. T-type calcium channels open at a more negative membrane potential, around minus 70 millivolts. L-type usually open around minus 40. So one of the currents driving the pacemaker potential is an inward calcium current, primarily the result of T-type calcium channels. Second current is funny. Yeah, that's its name. That's its name. It's called the funny current. It's an inward sodium current, also known as the funny current. Funny current. I stands for current, F stands for funny. So it is literally called the funny current. And that's because it was rather odd to the researchers that were studying it. They couldn't figure out this current. They thought it was funny. Funny as in odd, not funny as in ha-ha. Funny as in odd. But now it turns out it's a sodium current, so they named it the funny current. Now it's just kind of funny. What's not funny is the channel. Hyperpolarization activated, cyclic nucleotide gated. Oh man, that's a mouthful. Let's just call it HCN. Hyperpolarization activated, cyclic nucleotide gated channel. Well, we'll just call it HCN. These open when membrane potential repolarize, and they will close in response to a depolarization. So if they're opening when the membrane repolarizes, that is the reason this participates in the spontaneous depolarization of phase 4 or pacemaker potential. This channel, even though it's an inward sodium, it is technically a non-selective sodium and potassium. But let's think back. We had an example of a non-selective sodium-potassium channel. That was, are you saying to yourself, the nicotinic receptor? Excellent, excellent, both on muscle and in the ganglion. So the nicotinic receptor is a non-selective ligand-gated ion channel. Well, this is a non-selective voltage influence channel, okay, because it's activated by hyperpolarization. But just like we saw with the nicotinic receptor, when that opens, we see the sodium current, which is a depolarization. Hopefully you remember the mechanism for that. Why is that again? Yeah, excellent. If you said net force, kudos to you. Excellent job. Sodium net force is much greater than the net force for potassium because sodium is much further from equilibrium. So we see the sodium depolarization. Now, there's also an outward potassium current. This outward potassium current goes down, it gets reduced as the cell repolarizes. And hopefully this makes sense, that if I reduce an outward potassium current, if I reduce potassium conductance, do you remember from previous chapters? If I reduce potassium conductance, then the cell tends to depolarize. This potassium current contributes to the pacemaker potential. In other words, and it contributes in an opposite fashion. Remember, it is a reduction in the potassium current that allows the cell to depolarize. I'll say it again. It's a reduction in the potassium current that allows the cell to depolarize. Because remember, a potassium current is a hyperpolarizing current, not a depolarizing current. The potassium current plays some role. Really the biggest roles are sodium and calcium, but we won't forget this potassium current. All right, just like in non-nodal cells, the upstroke of the action potential is labeled as phase 0. This, again, we don't have fast sodium channels here, so this is the result of calcium, voltage-gated calcium channels, primarily the L-type calcium channel. Now, the slope of this change, or this rate of change in potential, it's not nearly as steep as a ventricular myocyte. That is something that contributes to the slow conduction velocity through the AV node. Remember, we said the slope of phase 0 was slow in an AV node, and that contributes to the slow conduction velocity. That's not a big player physiologically, or nor can I even think pathologically for the SA node since it's the pacemaker. But it is important for the AV node and conduction velocity through the AV node. Just as we discussed with nerve, just as we discussed with skeletal muscle, just as we discussed with non-nodal cells, the exact same thing. Repolarization is mediated by the voltage-gated potassium channel. So phase 3 in nodal cells, which is repolarization, is the result of the opening of voltage-gated potassium channels. This slide just illustrates what we just discussed. The purple is normal. Notice in the green, when you give norepinephrine, you increase the slope of phase 4, the pacemaker potential. Therefore, it gets to threshold sooner. Let's think about the pharmacology. What did we say? What is the impact here? Beta blockers, calcium channel blockers. Here's where they're going to come into play big time. By blocking calcium channels, remember that's part of the pacemaker potential. By blocking the beta receptors, that reduces cyclic AMP. So we reduce nodal excitability. This reduces automaticity. This reduces conduction velocity in the heart. All right, very important part in physiology, pharmacology, pathology, and thus step 1 will be things that alter these nodal cells. And the first will be the catecholamines. Norepinephrine coming from postganglionic sympathetic and also circulating epi. They both stimulate beta-1 receptors. And remember that the beta receptor is GS cyclic AMP. In fact, it is the prototype camper, cyclic AMP camping. So beta-1 is GS cyclic AMP. By stimulating cyclic AMP, hopefully you were thinking HCN, HCN. Yeah. By increasing cyclic AMP, we're going to increase that funny current. We will also increase calcium channel opening. Both of these are going to cause an increased slope of phase 4, our pacemaker potential, which means that the cell is going to get to threshold sooner. This, okay, location, location, location. At the SA node, the effect on the heart is increasing heart rate. This is a positive chronotropic effect. Remember, chronotropy means heart rate. At the level of the AV node, this is part of its positive dromotropic effect because it's going to increase conduction velocity through the AV node. So again, the effect at the SA node is to increase heart rate. At the AV node is to increase conduction velocity. It will also increase conduction velocity in non-nodal cells, as we indicated, because it will increase the slope of phase 0 in the non-nodal cells. In other words, the Purkinje cells, ventricular myocytes, atrial myocytes. Again, part of its dromotropic effect. All right, here's the picture of parasympathetic in the green versus the norm, which is in the purple. Hopefully, when we stated that M2 opens the potassium channel, you immediately said, well, that's going to tend to hyperpolarize the cell. Notice where the green line starts from, a hyperpolarized state. By inhibiting cyclic AMP, we reduce the funny current. So I am starting at a more negative membrane potential. I have a reduced funny current, so the slope is less, takes much longer to get to threshold. Slows heart rate, that's SA node. Slows conduction velocity, that's AV node. Let's think about some pharmacology here, and the answer is not digoxin. We're going to talk about another very important antiarrhythmic drug. Can we think of one that doesn't fit in class 1, 2, 3, and 4, not digoxin? If it doesn't fit in 1, 2, 3, or 4, digoxin's not what I'm looking for. Hopefully you said adenosine. Very good. Adenosine has M2-like effects. Now, notice I am not saying it's an M2 agonist. I'm saying it has M2-like effects. By having M2-like effects, it's going to slow down heart rate effect on the SA node and slow down conduction velocity through the AV node. Yeah, boy, you know, if you ever inject adenosine, you can literally stop the heart. It will go into asystole because of that M2-like effect what we're looking at in this picture. It takes much longer to get to threshold, and you can literally with adenosine. In fact, it's not uncommon at all. But the drug doesn't last very long, and the idea is a great way to try to stop supraventricular tachycardias.